Now let's talk about one of the cooler phenomena that exists, multifetal gestations. You've got twins, you've got triplets, on a rare day you may even see quads. And what better place to talk about multiple buns in the oven than a bakery? For the sake of simplicity, we'll use twin gestations as the basis for all of our examples here. But know that all of the following concepts can be applied to higher order multifetal gestations. When you hear twins, what's the first thing you usually ask? Whether or not they're identical. But what does this actually mean? Well, identical appearances come from identical genetic material, which has to do with zygosity. Zygosity refers to the number of zygotes initially involved. A zygote consists of two gametes, specifically an egg and a sperm, which is why there's two punched-in holes in this dough ball that look suspiciously like pronuclei. A dizygotic pregnancy is when the mother ovulates two eggs, symbolized conveniently by these two eggs, which are then fertilized by two separate sperm, symbolized by these two sperm-looking spoons. Ta-da! Two zygotes. Each zygote is genetically distinct from the other, so these types of twins are colloquially referred to as fraternal twins. Monozygotic multiples happen after one fertilized egg divides into, usually, two embryos. This means that the resulting fetuses are genetically identical. But wait, how about the placenta? Is there one big one? Two separate ones? Well, all of this depends on when the division of the zygote occurs. The fancy word for this is chorionicity, and it refers to the number of placentas. We'll represent placentas with these big round baking trays, because you can't bake bread without them. Before we go into more detail, you should know one more term, which is amnionicity. Amnionicity refers to the number of amniotic sacs, represented by the saran wrap that covers the buns. What combination of chorionicity and amnionicity you get depends on the zygosity as well as when the division happens. In general, the further the division is from the fertilization event, the more the fetuses share. Dichorionic diamniotic pregnancies have two placentas and two amniotic sacs. They're usually dizygotic. However, if they happen to be monozygotic, division must happen within 3 days of fertilization in order for it to have two placentas and two amniotic sacs. That's why the rising timer next to the two buns on two separate baking trays underneath individual saran wraps is set to 3 hours. Monochorionic diamniotic pregnancies, also known as monogestations, occur when division happens between 4 to 8 days after fertilization, so this timer is set to 8 hours. In this type of pregnancy, the fetuses share one large placenta, but they're each in their own amniotic sac, exactly how these buns are on the second shelf. Monochorionic monoamniotic, or mono-mono, or MOMO pregnancies occur when division happens between 8 and 12 days after fertilization. These fetuses have to learn how to share early. They share both a placenta and an amniotic sac, just like these buns on the third shelf. Mono-mono twins have a much higher mortality rate due to the risk of umbilical cord entanglement between fetuses since there's no amniotic membrane separating the two. That's why there's a red warning sign on this proofing shelf. If division of the zygote happens at 13 days or later, this is when you get conjoined twins. That's why this piece of dough next to the 13-hour timer is only partially separated. So what are the risks involved with having multiples? Seems like a decent deal so far. 2 for the price of 1. But not so fast. Unfortunately, the risk of pretty much everything goes up with multifetal gestations. Let's go over exactly what that means in more detail. First, we'll talk about how multifetal gestations affect mom. Basically, multifetal gestations compared to singleton gestations intensify the maternal physiologic changes of pregnancy. As you may remember from our maternal physiology video, there's a marked increase in blood volume during pregnancy, and this increase increases even more during a multifetal gestation. Therefore, moms with multifetal gestations have an even worse dilutional anemia, represented by these red H rolling pins floating in water. Also, this is further exacerbated by another fetus using up more of mom's iron stores, represented by this cast iron skillet. In addition to physiologic changes, mom is at an increased risk of multiple complications compared to her singleton counterparts. The risk for hypertensive disorders of pregnancy, including preeclampsia, is much higher in multifetal gestations. We'll remind you of this with this high-pressure steam escaping from the oven. The risk for gestational diabetes, represented by this jar of candy, postpartum hemorrhage, represented by this Jocelyn Peacock art retrospective invitation, You'll get this reference if you've seen our video on PPH. Thrombosis, represented by these clotted up whisks, and having a cesarean section, represented by the Caesar salad on this menu, are all increased in these types of pregnancies. One of the most significant risks of a multifetal pregnancy is the risk of preterm labor. While the exact mechanism hasn't been fully elucidated, it's thought that overdistension of the uterus, secondary to housing double or even triple the anticipated residence, contributes to spontaneous preterm labor. We'll remind you that overdistension plays a role in preterm labor with the sourdough starter pushing the top off of its container. Spontaneous preterm labor can lead to preterm delivery, which is one of the biggest fetal risks of a multifetal gestation. Speaking of fetal risks for complications and poor outcomes, these are also increased in multifetal gestations. As we just mentioned, preterm delivery is a major risk of multifetal gestations, and prematurity increases perinatal morbidity and mortality. Taken as a whole, up to 50% of multifetal gestations are delivered prematurely. That percentage rises markedly with higher order gestations, with practically all quadruplet pregnancies resulting in preterm births. Preterm delivery, which we've represented with these underbaked loaves being pulled from the oven, is usually either due to spontaneous preterm labor or a medically indicated reason, such as preeclampsia. Depending on the chorionicity and amnionicity, it may even be recommended to deliver in the preterm period because the risk for complications increases the longer the pregnancy goes along. Twins, or any order of multiples, that are born preterm retain the most well-known risks of premature birth, such as intraventricular hemorrhage and respiratory distress. Additionally, compared to their singleton counterparts, multifetal gestations have a higher risk of stillbirth and also death in the perinatal period. Most of the time, this is due to prematurity. While still in utero, there's an increased chance of intrauterine growth restriction in all multiples. There's even a special type of fetal growth restriction called selective fetal growth restriction, in which one twin is significantly smaller than the other, just like this bun is smaller than the one next to it. The definition of selective fetal growth restriction is one twin with an estimated fetal weight less than the 10th percentile or a difference in estimated fetal weights of greater than 25%. And the hits keep on coming. Compared to singletons and dichorionic twins, monochorionic twins have a higher rate of congenital abnormalities, symbolized by this anomalous loaf. And finally, children who were a part of a multifetal gestation are also at increased risk of cerebral palsy, represented by our recurring symbol, the pause hat. Before we head into our patient presentation, there's one more thing we have to cover, which is a complication of twins who share a placenta. Any monochorionic multifetal gestation is at risk of twin-twin transfusion syndrome, also known as TTTS. TTTS occurs in 10 to 15% of monochorionic pregnancies and is when there are arteriovenous anastomoses within the shared placenta. What happens as a result of the pressure gradient between arteries and veins is that one twin essentially becomes a blood donor to the other, resulting in severe anemia of the donor twin and polycythemia of the recipient twin. To symbolize this, we've drawn in two uneven buns connected by red and blue frosting. TTTS is a serious condition that can result in the demise of both twins, so we'll go over how to monitor for TTTS more a little later in this sketch. Okay, now let's dive into a patient presentation and the things you want to consider when dealing with a multifetal gestation. Women of older maternal age, specifically those at age 40 years old or higher, are more likely to have spontaneous multifetal gestations. In terms of any symptoms a patient may complain of that may tip you off that you've got multiple bundles of joy on your hands, increased nausea and vomiting is the main one. As we reviewed in our nausea and vomiting in pregnancy video, it's thought that increased placental mass and beta-HCG causes increased nausea and vomiting. Therefore, patients with multifetal gestations are at much higher risk of having nausea and vomiting during pregnancy, as well as hyperemesis gravidarum. In terms of risk factors for multifetal gestations, there are a few notable ones you should know. If the patient conceived via assisted reproductive technology, such as in vitro fertilization, the risk of a multifetal gestation is higher. We've symbolized this with this test tube-shaped mixing bowl. This used to be in part because multiple embryos were transferred during an IVF cycle, but that practice is slowly waning. However, since some assisted reproductive technology still relies on ovarian hyperstimulation, the rate of multifetal gestations is still higher in women who conceived via ART versus spontaneously. Associations have been made between dizygotic twins and a family history of multifetal births. Women who have a family history of twin births are at higher risk of conceiving a twin pregnancy. Moving on to our objective findings. Patients with multifetal gestations are at a much higher risk of developing preeclampsia, so make sure to check their blood pressure at every visit. On physical exam, the fundal height will measure greater than dates. We've represented this with these two large buns in a tall uterus dome. Since you usually start collecting fundal heights at around 20 weeks, hopefully you've diagnosed a multifetal gestation before then, but if not, this may be the first sign. In terms of labs, during routine second trimester prenatal screening, the maternal serum alpha-fetoprotein level will be elevated, which is why this basket of ALF's fresh produce is elevated up high. Typically, this should sound alarm bells for either a neural tube defect or abdominal wall defect. However, the MS-AFP is also elevated in multifetal gestation since more MS-AFP is made. Now on to our good friend, the ultrasound. The ultrasound is used a lot in multifetal gestations for diagnostics as well as monitoring. Let's start with diagnostics. Multifetal gestations are diagnosed definitively on ultrasound. You'll see 2 or more fetuses. In addition to the number of fetuses, you need to assess for chorionicity and amnionicity as well. As a reminder, that's the number of placentas and the number of amniotic sacs. Chorionicity is very important. This is because if the fetuses share a placenta, they're at greater risk for complications and poor outcomes compared to their singleton counterparts. The best time to determine chorionicity is during the first trimester, so we've made this first sound wave coming off of the scanner red. So how do you do this, you ask? Well, there are a few signs that should help guide you when you peruse placentas. If there are 2 distinct placentas that are not touching, it means you have a dichorionic pregnancy. That was easy. Another easy way to determine if the pregnancy is dichorionic is if the fetuses are different sexes, which means they're not genetically identical and cannot share a placenta. Unfortunately, it's not always this easy to determine chorionicity. A good way to distinguish dichorionic versus monochorionic pregnancies is by looking at where the amniotic membrane inserts into the placenta, also known as the membrane insertion site. If you have 2 placentas, which means the pregnancy is dichorionic, you'll see a twin peak or lambda sign at the membrane insertion site. This reflects a portion of the placental tissue that projects upwards between the interfacing amniotic membrane. It looks like this little peak between the 2 buns on separate baking trays on this top rack. On the other hand, if you have a monochorionic gestation, the membrane insertion site will look like a T with no protrusion of the placenta into the membrane interface. It looks like the straight divider between these buns that share a baking tray. If there's no dividing membrane, then you have a monochorionic monoamniotic gestation. Finally, as you get closer to delivery, you'll also want to assess which twin is the presenting twin. Whichever twin is closer to the cervix is twin A. Remember which twin is twin A, because his or her position is important when deciding on delivery planning. In addition to getting all the standard prenatal care of a singleton pregnancy, multifetal gestations may qualify for extra monitoring. Extra monitoring depends on chorionicity and amnionicity, so it's a good thing we figured out how to determine those. Starting at 16 weeks gestational age, monochorionic pregnancy should be monitored for twin-twin transfusion syndrome every 2 weeks. This is done via ultrasound. There's a specific sequence of ultrasound findings that will be evident if TTTS is developing. The first is the poly-oly sequence, when one twin has polyhydramnios and the other has oligohydramnios. The second is an absent bladder in the donor twin. The third is abnormal umbilical artery Dopplers. The fourth is hydrops in one twin. And the final stage is fetal demise in one or both twins. In addition to the monitoring for TTTS, if the pregnancy is also a monoamniotic pregnancy, your patient will need even more monitoring as these pregnancies have extremely high fetal morbidity and mortality rates. Many of these women are monitored as inpatients so that fetal well-being can be assessed frequently, usually starting between 24 and 28 weeks gestational age. Now let's move on to treatment for TTTS and delivery planning. In pregnancies complicated by twin-twin transfusion syndrome, the treatment is laser ablation of the anastomoses. This is when a specialist uses a laser to coagulate the pathological connections between the vessels and the placenta that have been causing the unequal sharing of the blood supply. Only maternal fetal medicine doctors are trained to do this procedure, which falls into the category of fetal surgery, a very cool subfield that deals with surgeries while the fetus is still in utero. Okay, now on to the main event, delivery. This bag down here is ready to deliver all these buns to their new homes. As with any pregnancy, you should know when the baby, well, in this case, babies, should be delivered and how you're going to deliver them. Di twins are delivered at 38 weeks gestational age. Mono-di twins are delivered between 34 weeks and 38 weeks gestational age. Mono twins are delivered between 32 weeks and 34 weeks gestational age. In terms of deciding the mode of delivery, if twin A, the lower presenting twin, is vertex, most of the time you can try for a vaginal delivery. If twin A is breech, then the risk for head entrapment and cord prolapse outweighs the benefits of a vaginal delivery, and a cesarean delivery is recommended. After delivery, mothers should have the standard postpartum follow-up. Rates of postpartum depression are higher in mothers who have delivered multiples, so it's extra important to screen for postpartum depression using a validated assessment tool, such as the Edinburgh Postnatal Depression Scale. A few more things before we wrap up. Because multifetal gestations are considered a major risk factor for preeclampsia, all women with a multifetal gestation should start low-dose aspirin, represented with our recurring symbol for aspirin, the umpire. This should be done between 12 and 28 weeks gestational age, but ideally before 16 weeks. Finally, due to the sharp increase in both maternal and fetal morbidity and mortality associated with multifetal gestations, some families opt for multifetal reduction early on in the pregnancy to reduce the number of fetuses. This entails selective fetal termination and is performed by a high-risk specialist, as there's also a risk of pregnancy loss of the other fetuses. Multifetal reduction is more common in higher-order multiple pregnancies, such as triplet pregnancies, and has been shown to decrease the fetal morbidity and mortality of the remaining fetuses significantly, as well as decreases mom's risk of developing complications such as gestational diabetes and preeclampsia. This is often a sensitive topic, but one that your patient and her family should be aware is an option, especially with higher-order multiples. Okay, looks like we've got all the buns baking. Before we leave the bakery, let's go over the info you're really going to want to have down pat. Dichorionic diamniotic gestations have 2 placentas and 2 amnions. Usually, these are dizygotic, as in genetically distinct, but if the zygote splits within 3 days of fertilization, then they would be monozygotic di twins. These pregnancies should be delivered at 38 weeks gestational age. On ultrasound, clues that you have a dichorionic gestation are 2 placentas that aren't touching, different fetal sexes, and the twin peak or lambda sign at the membrane insertion site. Monochorionic diamniotic gestations have 1 placenta, but the fetuses are each in their own amniotic sac. These pregnancies are always monozygotic. This happens when the zygote splits between 4 and 8 days after fertilization. The window for delivery is between 34 weeks and 38 weeks gestational age. On ultrasound, a monochorionic diamniotic pregnancy will show the T sign at the membrane insertion site. Monochorionic monoamniotic gestations have 1 placenta and the fetuses are both inside the same amniotic sac. These are very high-risk pregnancies because of the possibility of cord entanglement. Mono pregnancies happen when the zygote splits between 8 and 12 days after fertilization. These pregnancies require very close monitoring and are delivered between 32 and 34 weeks gestational age. If the zygote splits at 13 days or more after fertilization, then that's when you get conjoined twins. A special pathology unique to monochorionic pregnancies is twin-twin transfusion syndrome. This is when there are arteriovenous anastomoses between the fetuses within their shared placenta that causes unequal sharing of the fetal blood supply. As you can imagine, this leads to major complications, so these pregnancies are monitored even more closely with ultrasound. An ultrasound finding that you can see early on in the development of TTTS is the polyole sequence, where one twin has polyhydramnios and the other has oligohydramnios. The treatment for TTTS is laser ablation of the anastomoses. Finally, if twin A, the lower presenting twin, is head down, you can attempt a vaginal delivery. If twin A is breech, then the mode of delivery is a C-section. And with that, we'll bid our bun bakery goodbye. Until next time.